Okay, so today this is the third episode of LP Doc Talk, and today we welcome Dr. Michael Eng, who has been very gracious and lending his time for answering the questions that were submitted online. So we'll start from the first. Welcome, Dr. Eng. Thank you for joining.
My pleasure. Thank you.
So the first question that we got was submitted back on January 21st, and it was from Ann Arbor, Michigan. And I'll let you answer, Dr. Eng.
Okay, certainly. So the question is about sleep studies, about getting MRIs, and basically he's had several MRIs which look fine, hasn't not had any problems with his present sleep study except for a little obstructive apnea. And the question is, do you continue to get MRIs to look at the foramen magnum? And I would not. I think, as the parent suggested, it requires general anesthesia. It's not something to be taken lightly. And unless the child's having symptoms of true central sleep apnea, I would not get any further MRIs.
Good. The next question was from January 22nd and submitted from New York.
Correct. And that question is a little confusing to me because it says is that the person that's writing in has hypochondroplasia, but my mom has achondroplasia, and my dad does not. And so first of all if your mom has achondroplasia, the chance of you having hypochondroplasia and not achondroplasia is incredibly remote. That's first. So you probably have the same dysplasia your mom has. The second part is you want to get pregnant. Your partner is average stature. And what is the chance of the child of not being affected? If you have a skeletal dysplasia like hypochondroplasia or achondroplasia, it is autosomal dominant. And so if your spouse does not have it, the chance of your child being affected is basically 50%. So you have a 50% chance of having a child that's affected. Is there possibly the genetic prenatal diagnosis of the pregnancy? And sure, you can get ultrasounds, which can kind of give you a clue. You can also do what we call chorionic villus sampling and other things to get a better idea if the child has, a skeletal dysplasia. Third question is where all the tests can be done is, my third question is where all these tests can be done. And the answer to that is they can be done at most centers. It's not something out of the ordinary. So your OB or your OB should be able to manage you for this. Okay? That answers the second question.
Thank you. Yeah, go to the third one.
Sure. The third question is I have a 2-year-old son who was initially diagnosed achondroplasia and then changed to SED congenita. Then it was changed again to SEMD, but was not confirmed. Would the present drugs, 𝘾𝙊𝙉𝙉𝙑 or others, be able to treat this variant case? So 𝘾𝙊𝙉𝙉 is a particular drug that is looking at fibroblast growth factor receptor protein and looking at the defect in achondroplasia. So if your child has something besides achondroplasia, as far as I know, I'm not a geneticist, but I don't believe the drug would be of benefit. How soon will this drug be expected to be available? I do not know. And how much it's going to cost, I also don't know. So I was 1 for 4 with that one. The next question is Dr. Eng, I'm curious, what are your thoughts about limb lumping in achondroplasia. Some but not all doctors will do this and would like to know your thoughts and opinion. Hello. So pseudoachondroplasia is quite different than achondroplasia. It's a comp issue, and it affects the epiphysis. And so people with pseudoachondroplasia are much more prone to developing premature arthritis than other people, and much more so than achondroplasia. By putting stress across the joints, you're hastening this. So, limb lengthening has a lot of social issues and other things, why you're trying to accomplish this. But in addition to that, if you lengthen somebody with pseudoachondroplasia, you're much more prone to having them developing premature arthritis in their hips and knees and ankles, leading to joint replacement and other things. So, I'm not a big proponent of this in any case, let alone in this situation, because you might wind up taller, but certainly functionally you're much worse off. That's the answer to that question. Next question is, I'm a 15-year-old achondroplastic girl. I want to ask about surgery that can make me taller. I want to know more details about it, please. Is it too late, as I am 15? So, and this is from Cairo, Egypt. And the question is, the things that can make you taller are limb lengthening. And limb lengthening is a way where we cut the bone and slowly stretch it over time. At the age of 15, you are definitely not too old to have this done. However, it's fraught with complications, and you just need to be aware of them and what you're hoping to accomplish. And it's a big commitment out of your life. It's a several-year commitment. So it's something that can be done. You're definitely not too old to have it done, but it's definitely something you really need to have a long sit down with your physician about. Okay. Next question is from Trish from Ireland. Hi all. My son is 4.5 and has achondroplasia. Very active boy. Loves all sports, a typical 4-year-old, playing, running, etc. He has bowing of his knees, 𝘾𝙊𝙉𝙉𝙑𝙀𝙁, which seems to be due to ligaments laxity at the knee joints, not due to bones in the lower legs, according to his orthopedic consultant. They have recommended bracing of his legs to try and correct his bowing. He never complains of pain in his legs. As I said, he's an extremely active, happy boy. We feel that bracing will restrict him greatly. I completely agree. However, this is something that will prevent him running into knee and hip problems later on in life. We go with bracing. The reading I've done online doesn't favor bracing. Is there any evidence based for bracing? Are there any other options to correct bowing? And what degree of bowing, under what circumstances would you consider it necessary to treat bowing? Well, this is an excellent question, and you've done your homework. There is no literature to support bracing. Bracing does not work to correct bowing in achondroplasia for multiple reasons. One is the extremity is so short. B is the force that you would need to place on the leg to correct it is quite severe. They do have ligaments laxity, but I'll bet you $1, Trish, that it is the bone that's causing the bone. Now, to answer your second question is when to do corrective surgery, if at all. Well, there's 2 indications to correct bowing in achondroplasia. One is if he's having significant pain, and as you said, he's not. So that one's thrown out the window. The second one is if he has something called the fibula thoracic. What is that? The fibula thoracic is where the tibia, which is the bone below the knee, gaps open when he's walking. It's only something that you can see while he's walking. So it's not. So if you sent me an X-ray, it'd be hard for me to see. If I looked at a video or if I saw obviously better in person, I'd be able to tell. But typically, if he's not having pain and he's not having the fibula thoracic, I would leave him alone. I would not brace. I would not do surgery at all. Okay. Next question is from Hamilton, Ontario. My son has been diagnosed with SCDC. He has a 𝘾𝙊𝙉𝙑1 mutation, that's a type 2 collagenopathy. The mutation is a splice site mutation. It does not match the usual any other more common mutations found in the literature. He has grown 6.5 inches since birth. Okay, has met all his milestones so far. He is a little less than the first percentile in growth for average stature babies. However, he has a majority respiratory issues, been in the hospital 5 times in the last 5 months. Is this common with this condition? So children with SED or SEDC can get respiratory problems. This is kind of one end of the spectrum, meaning this is fairly significant. You told me he's grown 6.5 inches. Unfortunately, I don't think I have his age, because that would be helpful. But some of these children do get into pulmonary issues. One is, just clearing viral infections. Two is the chest big enough to handle, things. So, it'd be nice to see him and examine him, maybe even get an X-ray. He even has in drawing chest retractions for his baseline breathing. He's on nebulized treatments and reflux medications also. So reflux, which is where the gastric contents kind of float back up or go in the wrong directions, can cause serious lung problems. Meaning is you can aspirate, meaning these gastric contents, instead of staying in the stomach, can go up and actually go into the lung and cause like a pneumonitis, which can cause significant pulmonary issues. And this is maybe what's happening with your child. So I look at that very carefully. Have your pulmonologist look at that. Is there anything else to help our baby? Have we overlooked something? So the first thing I would look at is the reflux to make sure you're not getting chemical pneumonitis. Also looking at the size of the chest cavity. Okay. So I think this is from Alicia. We're moving on to another question. I was wondering if it's necessary for my daughter, who's an achondroplasia, to have at least one MRI, or does there need to be a concern? She's had no sleep study, no MRIs, and has not seen anything. So this is a great question. In the American Academy of Pediatrics, they recommend that children with achondroplasia get MRI early on in life. Personally, and I'm talking to several of my colleagues, I disagree with this. Why? MRI is not a benign thing, and we don't operate on X-rays. If a child is developing perfectly normal and there's no evidence of sleep apnea and is doing quite well and functionally, I don't think the child needs an MRI or a CAT scan of frame of magnet. So that's my opinion, and like I said, some doctors are going to differ from that, but that's how I think. But you want to make sure the child's functioning well, developing well, and there's no evidence of sleep apnea. Okay. I don't know if this is the same person or not. She's a runny nose for 6 months now, wakes up and screams multiple times a night. Those are my concerns, but my doctors have no experience telling me that she is perfectly fine. Same person. So if she has a runny nose for 6 months, wakes up and screams multiple times, so that's two separate things. Meaning is, and here again, I don't know how old your daughter is. No child should wake up and scream multiple times a night. There's something going on. Runny nose now could be ear problems, sinus problems, etc. So I would investigate that a little bit closer. Okay. Please, could you give me the medical term for my type of dwarfism? I'm 4'7". However, this was reduced to 4'6". I was born with scoliosis, curve, lower and upper spine, no arches in either feet. Although when born until about 7, my head was out of proportion. This settled into proportion after now, although a dwarf. I'm a proportion, so I'm lucky than a lot, although I grew up being considered less than those of so-called normal size. I now get coccidiosis requiring hospital treatment. I have osteoarthritis throughout the spine and joint, including thumbs and angina. All I've been told, normal part of dwarfism. Okay. I grew up with the saying that what could not be cured must be endured, but what does not kill you makes you stronger, and don't mean that, laugh out loud. I was little, wish just like, as much as about my type of dwarfism. I'm 54. I have one daughter and grandson, saying my youngest of normal height. There was another grandson who died at age 3. There are severe congenital problems, esophageal, cleft palate, etc. Usual spinal sound, and needs frontal plication. Okay, so you gave me a lot of information, and unfortunately, I can't tell you what type of dwarfism you have based on what you're saying. I know you're from the United Kingdom, which is great, but I cannot tell you based on this information what type. Just for you to know, there's over 400 types of dwarfisms or skeletal dysplasias. And without clinically looking at you, examining you, and looking at x-rays lots of times, it's essentially almost impossible for me to make that diagnosis. So I apologize. Okay. And I said, you don't do that. Arthropathy. My question is, are there any special precautions in the use of fluoroquinolones in children with dwarfism? I don't know why you're asking this, because sometimes fluoroquinolones are used in, I believe, rheumatoid arthritis. You have to be very careful in children about doing this. And I'm probably not the expert to ask, but I'd be quite concerned. And I'd make sure I see a rheumatologist who specializes in it. And since kids with dwarfism already have issues with bones, do the fluoroquinolones cause even more havoc? I would imagine so. And like I said, in children, I'd be very hesitant to take them unless you're being monitored extremely closely. Okay. The next question, because this is a separate question, is from Carruthers, California. The background for this question: my 2-year-old son has brachytelephalangic chondrodysplasia punctata. He's had a tracheostomy since birth due to mid-phase hypoplasia. My understanding is that defective syndrome is in the cartilage of the epiphyseal plate. His lungs and immune system are in good shape, but he keeps getting hit with respiratory infections due to the tracheostomy, also probably due to a small lung volume. In order to attack the bacterial infections, he had numerous rounds of fluoroquinolone. Oh, maybe this is the fluoroquinolone question. He always seems pretty beat up during the time he's taking this antibiotic. This antibiotic that's quite strong, even if the respiratory bug is vanquished. But he's not old enough to really specify what kind of pain he's in. I don't want to second guess the prescribing physician, but I wonder if there's any dwarfism specific things that need to be considered. Chondrodysplasia punctata, hard clearing infection. You have a small lung cavity, so in terms of you're not moving a lot of air in and out. I am not an expert on antibiotics, obviously, when we've been talking about fluoroquinolones before. So I'm not your best person to ask this question to. Okay. He probably has a severe respiratory infection that they're using such a strong antibiotic. Next is from Chicago. My son is 8, been diagnosed with achondroplasia. He's always had a faint visible vein lines between his eyes. Yes.
I was going to touch on the previous question. Who should they contact? The rheumatologist you mentioned?
I said they should contact the rheumatologist because some other medications who are similar fluoroquinolones are used for that. I think I got confused with these two questions. But this, he definitely should be seen by a pulmonologist. So I don't know if there's two separate questions. One was asked about fluoroquinolones in child with dwarfism, like the question above when he was talking about severe.
Yeah.
And then the next one, it just seems very, what's the word I'm looking for, coincidental that there's two separate questions about fluoroquinolones. But in terms of the second one, the kid with the respiratory infections, a pulmonologist is definitely the person you would seek out. If you're having joint pain and getting medications for that, then rheumatologist. If you're having pulmonary infections, lung infections, pulmonologist is the person.
Right. Okay. Yeah, I'm sorry for the confusion there. In the printout, maybe it didn't have the lines, but it is one question where it starts from the floor. It says my question is this, and then ends at before it says my.
This isn't the one. So this is the same question with the
Preston, from the
coccidio
same person.
from the United Kingdom?
No, from Carruthers, California. So the
Yeah, that's right.
California,
Yeah, but that's what I'm saying. Like one of them, right? Okay, because the one from the United Kingdom also had fluoroquinolones. I thought. Oh, maybe that was the first part of the question.
that was the first part of the question.
Oh, okay, I got you. Oh, okay, I got you. Then, so right, don't see a rheumatologist, see a pulmonologist or an infectious disease expert. I thank you.
All right.
Okay.
Perfect. So the next question, yeah, my son is 8 months old.
Okay, my son is 8 months old, been diagnosed with achondroplasia. He's always had these faint visible vein lines between his eyes and temple, but nose is becoming more prominent. 1 month old, he had done an MRI and seen that there was a slight fluid level increase in the skull, but the neurologist did not seem concerned with that amount. His ENTO told he had a moderate obstruction, not central, but at this point, you recommend we keep an eye on his breathing progress, using nasal saline to follow up every 3 months. So is this prominent appearance of facial vein indication of neuro ENT issues, or is it normal? Well, it could be all the above. It is a little concerning that, there might be some venous congestion or some maybe some hydrocephalus or tightness foramen magnum. So you really want to go back and see how well he's developing. And possibly this is a time you might want to re-image his foramen magnum. Earlier I talked about how I was somewhat opposed to doing that if everybody was doing great. But if these veins are becoming more prominent, how's his sleeping doing? I would definitely think about re-imaging his foramen magnum. Okay. I think the next question is from New Brunswick, Canada. My daughter, who is 14 months old, is still not sitting. I don't see it coming anytime soon. Should I be worried? She's pulling herself to stand, but sitting she still can't do. Well, children with achondroplasia do sometimes take a while to sit. Is she, is she hypo, meaning is like her muscle tone is decreased compared to she have a bigger head? I think she just needs to be looked at a little closely to see if she's still making progress. Is her head circumference growing at a rate that is appropriate for her age, based on a chondroplastic growth chart? I wouldn't get too concerned as long as those other things are okay. And then the question is from Birmingham, do you have any idea when the trials, including drug administration of BMN-111, will begin? And I have no idea. And then as a doctor and as an individual with achondroplasia, what is your view on the ethics of developing a drug to help treat the medical condition of achondroplasia? In your opinion, do you feel a drug will be successfully developed in the next 3 to 5 years? And what are the positive benefits of back? I don't know if that's the same question or not. So let's answer those first two questions. So as a individual, I think if there's a drug or a medication that's developed that can help alleviate many of the complications of achondroplasia, such as foramen magnum stenosis, lumbar stenosis, bowing of the leg, things like this, I'm all for it. I think it's great. And so I have no problem with it, and I would support it completely. I think, just like in a lot of other things in medicine, we want people to function more easily and without pain. What are the positive benefits of back surgery on a child with achondroplasia? What are the negatives? Well, you only want to do back surgery on a child with achondroplasia if they're having symptoms. What are the symptoms? Pain, progressive kyphosis, or evidence of spinal stenosis, which is narrowing the canal and difficulty in walking distances. So one of those three things are there, then surgery can be very beneficial. What is negative? There's risks involved to all surgeries, and you should go somewhere where they've done the surgery before, and they're comfortable in taking care of people with achondroplasia. and that you have confidence in them. It's not something to be taken lightly. Wow, I think I'm out of breath. I think was that the last question, Amir? Hello?
That was great, doctor, and thank you so much. I had myself on mute there.
No problem. I understand completely. Okay, are we good?
That was the last question. Yeah, we're done. Thank you so much.
I hope I did okay. Thank you.
Yeah, let me just stop the recording here. I don't see anyone else online, so I don't think there's any live questions. So I'll just stop the recording here. And
okay.
again, thank